by the Ministry of Health, University of Botswana, with us at the Faculty of Medicine, and also Rutgers University. For those who have not joined our mailing list, this session is over Zoom, as you all know. And please make sure that your microphones are muted during the presentations to avoid a lot of echoing. Like last time, you can use the chat function to post questions, and we will have a moderator who will use questions and answer some of them as the session continues. Please be informed that this session will also be recorded today and will be made available both in terms of full recording and the slides that will be presented soon. We appreciate your feedback, so please make sure you do give us that so that it can help us suggest on how to improve and also what topics will be relevant in the near future. Today's theme is on COVID-19 epidemiology, case definition, and testing. 3 different topics covering an important theme. And we have 3 presenters today. First, Professor Jarvis, and then Dr. Lynn Tjirare-Ookame, and then lastly, Mr. Maruping. Without wasting more time, I would like to start with introducing the first presenter. It's a great pleasure to introduce Professor Jarvis, who will take us through the epidemiology part for the next 10 minutes. Professor Jarvis is a Professor of Tropical Medicine and International Health at the London School of Hygiene and Tropical Medicine. He's also associated with the University College of London Hospital, Princess Marina Hospital, and Botswana-Harvard Partnership. Professor Jarvis is also an honorary specialist physician. He's an honorary consultant in infectious diseases and clinical epidemiologist with main research interests in advanced HIV disease and associated opportunistic infections. His high impact research has informed policy and guided guidelines both locally and internationally. And we have had the pleasure of him working in Botswana for the past 7 years. Please, Professor Jarvis.
So thank you very much for the kind introduction. I'm going to very quickly just run through some of the background and epidemiology of COVID-19. So it's hard to remember now that this has only been around since the beginning of this year, really. And it first came to light when the WHO was alerted to a cluster of pneumonia of unknown etiology in the last day of 2019. So that should be 31st of December 2019, obviously, rather than 2020. Sorry about that. And it was very rapidly identified that this pneumonia of unknown etiology in Wuhan in China caused a severe acute respiratory syndrome and was caused by a coronavirus, which was initially called SARS-CoV-2, to distinguish it from SARS-CoV-1, which was the first SARS virus. And the resulting illness was named COVID-19, so that's coronavirus, and the 19 is because it was discovered in 2019. And this virus, which started in Wuhan in China, was quickly identified and sequenced. It was found to be something called a beta coronavirus, which is the family of viruses that cause some common colds and also SARS and MERS. It's an enveloped non-segmented RNA virus, and exactly how it got into humans is unknown. The first cases, or lots of the first cases, were associated with what's called a wet market, in Wuhan in China, where they sell live animals, including lots of wild animals. The virus sequence suggests that it's a bat coronavirus, so it's almost certainly come from bats. Exactly how it got from bats into humans is not clear. It may have come directly from the bats, or it may have come through an intermediary species, but we're not certain yet. But at this point in time, it doesn't matter exactly how it got from bats to people, it's in us. So next slide, please. How does this infection spread? Well, the main route of spread is through respiratory droplet transmission. So for respiratory viral infections and other respiratory infections, there are two distinct means of transmission. One is via aerosols, which are very small particles that stay in the air for a long time and can be breathed in unless you're wearing a respirator mask. The other is through droplets. These are larger particles. These are globules of saliva that are spat out or coughed out, and people are coughing and talking directly into people's mouths or mucous membranes to cause infection. And this is spread through respiratory droplets. But it's not just being coughed on or the droplets coming from people talking. If this lands on surfaces, it can survive on the surfaces for some time. It can survive on plastic for up to 2 or 3 days, and on metal for potentially 3 days. So hand hygiene, washing your hands, disinfecting surfaces is also very important in helping stop transmission of this infection, so that you don't inoculate yourself with this infection, having picked it up from touching a surface or somebody's hand, and then put that into your mouth. The mean incubation period from when somebody's exposed to the infection to when they develop the first symptoms of disease is about 5 days. It can be as early as 2 days, and 7 days, about 75% of people will have developed symptoms. By 10 days after exposure, 95% of people who are going to get ill will have got ill, and a very small number of people, it takes slightly longer than that. But on average, it's about 5 days. Asymptomatic transmission does occur. So there's now very good evidence showing that people can actually spread this infection before they develop any symptoms. So in the 2 days or 3 days before people become symptomatic, they can actually be spreading this infection. And there are some people who never seem to develop any symptoms at all, or only develop very mild symptoms. And the evidence suggests that they may also be infectious, but the exact contribution of that to the whole picture of infection is not known yet. The reproductive number is approximately 2 to 2.5. So that means that every infected person, if we do nothing, will infect between 2 and 2.5 other people. So that means that the infection rate doubles very quickly, because each transmission cycle, you're getting a doubling in the number of cases. But there's data showing that, in fact, early in the disease, it may be even more infectious than that, with reproductive numbers of 3.6, or recent studies reported as high as 5. So that's each person infecting between 3 to 5 other people early on the course of infection. So it's a very infectious pathogen. Next slide, please. So what happens when people develop illness? Well, the vast majority of cases, fortunately, are mild and don't cause severe illness. It causes mild respiratory symptoms. You can get a fever, you can get a cough, you can get some shortness of breath. There seem to be all sorts of other features which are being described, including some gastrointestinal upset and so on. But the problem is that a proportion of patients, somewhere between 15 to 20% of confirmed cases, require hospital admission, and a proportion of those get very sick and they require intensive care. And the reason they require intensive care is they need ventilation to maintain their oxygenation. And the factors that are associated with needing to be hospitalized and needing to have ventilation at older age. So the rate is markedly higher in those over the age of 60, and other comorbidities, particularly cardiac comorbidities and pulmonary comorbidities. Smoking is also a risk factor for developing severe disease and needing ventilation. We don't yet know what the effect of HIV is on this. The limited data that are out there suggest that people who have a suppressed viral load and are stable are at no higher risk than anybody else. So the hope is that as long as people are effectively controlled on ARVs, the risk of them getting severe disease is not going to be any higher than anybody else. But of course, with people with uncontrolled HIV, that's going to be different. And the case fatality rate overall ranges in series of between 0.5 to 4%, but it depends on how many cases we're identifying. If you're not doing much testing and you're only identifying the very sick cases, then of course your case fatality rate will be higher. If you're doing lots and lots and lots of testing and identifying all of these quite well people, your case fatality rate will be lower. And it's likely that the true value is somewhere around 0.7% of all of the people who get this infection will die from the infection. So that might not sound very much, but actually when large numbers of people get infected, then that's quite a big number. So here are the global cases. And you can see that this is increasing on what's called an exponential curve. In other words, the doubling rate is consistent. And we now have over 1.5 million confirmed cases in the world. Just a few days ago, that was only 1 million cases. So this is a huge problem. And of course, 0.7% of 1.5 million is quite a big number. So it's quite a considerable number of deaths. Next slide, please. So the epidemic trajectories of COVID-19 have been very different in different places. So these are the curves looking at the United States of America, USA, and South Korea. And both countries reported their first case on the same day, the 22nd of January. But the countries responded very differently, and you can see the difference in case numbers here. So South Korea put in place very rapidly widespread testing. They tested all symptomatic patients that they could find. They did very rapid contact tracing, very aggressive quarantine, and you can see that they've managed to control their epidemic. Whereas the United States didn't do any of that, and you see where they are now with well over 500,000 cases. So almost half of all of the cases in the world are in the USA, and they've only now started to institute lockdown measures, which are hopefully going to dampen down the role of infection. Now, what's happening closer to home? Well, if we look at the next slide, this is showing us the numbers in South Africa. So on the left-hand graph are the pictures up to the 27th of March, and the blue line are the case numbers in South Africa. And the orange line is the epidemic that we'd seen in Italy, up to that point, the biggest one in the world. And South Africa was tracking the Italian case numbers about 26 days later. So if you'd asked me on the 27th of March what was going to happen, I would have said there'd be tens of thousands of cases in South Africa by now. But that didn't happen. Something rather odd has happened in South Africa. And on about the 27th of March, those case numbers started to flatten off, and they stopped following that Italian trajectory. And if we look at the graph on the right, we can see that that's continued, and the South African cases are not increasing at anywhere near the same rate as the cases increased in Europe and in North America. Now, if we look at the next slide, we can try and figure out why that might be. So South Africa, like Botswana, put in place a lockdown, but that lockdown was only put in place on the 27th of March. So it's impossible for the lockdown to have caused that decline in case numbers, because when you put a lockdown in place, it takes about 2 to 3 weeks at least before you start to see your case numbers reducing, because of that incubation period of 5 days, and then the time it takes for a person to get really unwell, which is up to 10 days. Those people who are presenting with infection probably acquired their infection about 2 weeks ago. So it takes at least 2 weeks or more for a lockdown to have any impact on case numbers. So it can't just be the lockdown. Maybe it was the travel ban that was put in place, because a lot of the cases in South Africa, like in Botswana, were imported cases. So if you stop them being imported and you put in place very good contact tracing, maybe that reduces the case number. In any event, we're not very sure why that is, and we need to keep a close eye on things in South Africa because, of course, that has a big impact on us in Botswana. So next slide. So where are we at the moment in Botswana? Well, as of today, this update sort of is we've had 2 new cases reported today. So we have 15 cases in total, and we have 1 death. And of those 15 cases, the majority are in people who've traveled overseas to either South Africa or the UK or other places, and they've caught their coronavirus there. But we now have several cases of infection which have been caught locally in Botswana from people who we know have been in contact with these cases who've been acquired overseas. And we also have 1 case in Botswana where we're not entirely sure where that individual acquired the infection. So what that shows is that there's definitely what we call local transmission happening in Botswana. That's infection that's being caught here rather than overseas. And we may also have what's called community transmission happening in Botswana. So that means that this virus is circulating out there in the community, and it's going to start cropping up in people who had no contact with any of these known travelers. So we need to keep a close eye on that because our numbers may increase quite rapidly over the next few weeks. Next slide, please. So what could happen here? Well, these are some very preliminary models just showing this is now the critical care bed capacity in Botswana based on various projected scenarios. So the red line is looking at an uncontrolled epidemic. So this would be the case if we did absolutely nothing at all. Now, obviously, that's not what's happening. We've already put in place lots of measures, travel restrictions and lockdown. But if we did nothing, what could we expect? Well, what we could probably expect would be something along the lines of that red line. That's the number of critical care cases that are needed, the number of patients who need ventilation. These graphs start at about 100 patients in the country. So you can see that about, sorry, actually, no, that's not true. These graphs start at 1 patient in the country. So you can see that about a month after you have 100 cases or so, your epidemic takes off, about 2 months after the first case. And then about a month later, you get your peak of the epidemic, and then it declines. And at the peak in Botswana, we'd have 3,000 patients who would need to be on ventilators in intensive care. The whole country has, at the moment, only about 30 to 40 ventilated beds. We could increase our capacity by getting the teaching hospital fully operational to about 100 to 150. So we'd massively exceed our intensive care capacity, and we'd have about 15,000 deaths in the country if we did that. If we reduce social mixing by about 20%, which would amount to shutting down large gatherings and putting in place some fairly minor social distancing measures, you would see that we would flatten the curve, but we'd still have about 2,000 patients in intensive care at any one time. And if we reduce mixing by 40%, which is quite an aggressive reduction in social mixing along the lines of the kind of thing they've been doing in Japan or Singapore, we could flatten that curve down, but we'd still require almost 1,000 ICU beds. So what we want to do is prevent any of this happening at all by putting in place the lockdown. And the hope is that with the lockdown, we can stop even the small epidemic from happening, and we can keep the case numbers very low. But the difficulty is that if we lift these lockdown restrictions, unless we've put in place very, very widespread testing and rapid contact tracing and quarantine, we're still back at square one, which is that these epidemics would just take off again, basically. So the current strategy in Botswana is that we've got lockdown in place. We're hoping to suppress any epidemic from taking off. That will work. There's very good data that lockdowns work, but the question really is what we do next. And what we have to do next is really scale up testing, contact tracing, and quarantine so that when we release the lockdown restrictions, then we will be able to manage case numbers. But the unfortunate answer is that nobody yet's managed to get to a place or a position where they've effectively lifted their lockdown yet. So we're just learning how to do this. We're going to have the advantage of being able to watch what happens in China and in Europe and in the US over the next few weeks, and then we can work out what we can apply from what we learn there to the Botswana epidemic. So that's the end of this brief talk, and happy to answer any questions.
Thank you very much, Professor Jarvis, on that fantastic presentation. We actually, I should have mentioned it when we started, but we have received a lot of good questions before the webinar started today. And these questions were sent to different presenters so that they would be able to be covered during the presentations themselves. If some of you, though, still remain with a number of questions afterwards, this will be taken after all presenters have presented at the end of the session. We'll now proceed further, and I have the pleasure of introducing the next speaker, who is Dr. Lynn Tjirare-Ookame. Dr. Tjirare-Ookame will elaborate on case definition for the next 5 minutes. She works at the Ministry of Health and is currently doing Master of Medicine in Public Health at the University of Botswana. Please, Dr. Tjirare.
Good afternoon. Good afternoon. Sorry for that delay. Okay, I'll go briefly through the case definitions for the COVID-19. But before we do go through the case definitions, let me just start the presentation by saying case definitions are a critical and very essential part of any epidemic or outbreak. And they could be crafted for different purposes. But what is important is the uniformity of classification and also reporting systems. I think it is essential that we do understand that the case definitions have purposes. They could be for clinical definitions or either for public health surveillance purposes, as well as an outbreak investigation, as well as epidemiological studies. So for one outbreak or epidemic or pandemic as we have COVID-19, there might be a variation of the case definitions depending on the status of what it is for, whether you are investigating an outbreak, say there's an outbreak in Lobate and so forth. So it is important to understand that they don't necessarily have to be the same. Another point is to understand the sensitivity and the specificity of a case definition. So sensitivity talking to the ability to detect the cases. Specificity really meaning the ability to exclude the non-cases. So that is also important to keep in mind. So I'll go through the, okay. So I'll also point out that, you know, the case definitions that we are having now and that the criteria that is worldwide accepted is to have a clinical criteria, a lab criteria if it is a disease that requires such as we do have for COVID-19, and an epidemiological criteria, meaning the time, place, and person. So those are also important to have, but they may not be in a clinical definition. The epidemiological part may not necessarily be in a clinical case definition for an outbreak of a pandemic. So basically, a case definition has to be simple, it has to be accurate and very practical, not open to any interpretation. Okay, next slide. So these are as depicted in the WHO the World Health Organization, defining a suspected case. So a suspected case is a patient with an acute respiratory illness having a fever and, and there is important, fever and at least one of the signs of respiratory disease, meaning cough, shortness of breath. And there's another end that says a history of travel or residence in a location reporting community transmission of COVID-19 during the 14 days prior to the onset of symptoms. The 14 days there is it's crafted because of the epidemiological trend of the COVID-19 symptoms manifestation. From the bell curve, the average is about 5.7 days for someone to get to show symptoms, but generally 2 to 14 days is the accepted time to present with symptoms. So B, for a suspected case, is a patient with any acute respiratory illness and having been in contact with a confirmed or probable COVID case in the last 14 days prior to the symptoms onset. So probable case definition will come down, so we will be lower down in the presentation to be able to fit there. Next slide. The C part says a patient who is hospitalized with a severe acute respiratory illness and at least one of the symptoms or signs of a respiratory disease and requiring hospitalization and in the absence of an alternative diagnosis that fully explains the clinical presentation. Next slide. So here I'm depicting the clinical definition, case definition that we'll be working on. It says a patient with acute respiratory illness with sudden onset of at least one of the following: cough, sore throat. So the fever, as per the WHO case definition, because we want to increase the sensitivity of the case definition here, we dropped the and that is why it reads thus. So fever is not necessarily a requirement. So also a history of travel outside of Botswana and to a location within Botswana reporting community transmission of COVID-19 during the 14 days prior to the symptom onset. Or a patient with any acute respiratory illness and having been in contact with a confirmed or a probable COVID-19 case. I'll talk to the definitions of a contact as I go through the presentation in the last 14 days prior to the symptom onset. Or a patient who is hospitalized with severe acute respiratory illness and in the absence of an alternative diagnosis that fully explains the clinical presentation. So you can see that there is a very minimal difference from the WHO definition, but the difference that is accounted for the fact that we want to increase the sensitivity of the case definition here. Next slide, please. So a probable case. So the definition that we will continue having in Botswana is similar. It's exactly similar to the WHO case definition of a probable case. So A being a suspect case for whom testing for COVID-19 virus is inconclusive. Inconclusive pertaining to the lab testing. So the lab should say that they tested the specimen of a suspect case and the result is inconclusive. Or a suspect case for whom testing could not be performed for any reason or is pending. It is necessary for us in Botswana, given our turnaround time, to include pending there, because sometimes a suspect case is tested, and because of the number of days we do take to get a result, therefore that patient then becomes a probable case. Next slide. A confirmed case will then be a person with laboratory confirmation of COVID-19 infection, irrespective of their clinical symptoms or signs. Therefore, if we do have a case who presented initially without symptoms and is tested, that person is a confirmed case and will be treated as other confirmed cases are treated in isolation. Treated meaning handled. Next slide. So just to give you a few updates pertaining to the testing. So testing started on week 5, well, week 5 of the year here. So we had the depicted number of tests were done. So in week 15, we had around 7 cases which were notified. But I think the graph maybe is outdated. So we know that by today now we have 15 cases who have been tested positive. Next slide. Laboratory testing. So our data is not up to date as in today, but what we have received, the total number of samples that have been received from facilities is 3,656. Those that were tested from suspects, cases, and contacts, 923. Those from those who were quarantined or in self-isolation and in prisons were 2,733. The specimens on the 13th of April, including the 17th, including the 67 prisoners who were tested, were 176. So tested samples and resulted cumulative were 3,441. Those that were negative were 3,428, and the total positives were 13. So like I did say, they are not up to date as of today, as we know that we had 2 more cases today. I think that's the end of my presentation.
Thank you very much, Dr. Tjirare-Ookame, for this wonderful presentation. We have received a lot of questions beforehand that specifically also dealt with this issue of case definition. So we're very happy that we managed to get thorough, detailed insight into that. It is also now timely to actually go further, and we'll now dive into the practicalities of doing the testing itself. To help us go through this, I'm proud to present our last speaker, Mr. Maruping, who will take a step-by-step detailed assessment of this. Mr. Maruping works at the National Health Laboratory at the Ministry of Health and Wellness. He's the principal medical scientist at this laboratory and has a bachelor's degree in medical laboratory sciences, and is also a researcher with more than 8 co-authored peer-reviewed publications. So he's the right man to really show us how it should be done. So please, I leave the floor to Mr. Maruping.
Thank you very much. Good afternoon, everybody. I'm just going to take you through. Note that the presentation states that we are going to be discussing testing, but I will only discuss issues pertaining to sample collection and shipping to the laboratory. Details on testing technologies will be arranged in the next presentations. Okay. We have a lot of possible samples that we can collect for us to do investigations or test for the COVID-19. We have we can use sputum. we can use serum, especially when we do antibody testing. We can do, can also take whole blood, urine, but the most preferred sample for the scenario that we have in our country is the nasopharyngeal and the oropharyngeal swab because of the easiness of collecting the sample. Literature informs us that because this is a lower respiratory tract infection, the best sputum that usually gives a good yield as far as testing the COVID-19 is sputum. But you might be aware that it is usually not easy to have patients having productive cough. So this is why we prefer nasopharyngeal swab or oropharyngeal swab, which is easy to collect. And for us to collect this sample, we need the dacron or polyester flocked swabs. Note that the wooden swabs are not recommended for this sample collection. And the good thing about this is the samples after they've been collected, they can be stored at 4 degrees Celsius before they are shipped to the laboratory. And they can stay up to, I don't like advising people 5 days. Usually I tell them 3 days so that they send them to the lab faster so that we beat the turnaround time. Usually after collecting the swabs, you want both the nasopharyngeal swab and the oropharyngeal swab to be placed in one viral transport media so that you increase the viral load and hence increase the chances of picking the organism through testing. Ladies and gentlemen, you are aware that every science that you want to do, you want to perform science that is safe to yourself, the environment, and the patient. As such, it is very important that you observe safety protocols. And it is very important that every laboratory should conduct a local risk assessment just to ensure that the lab is competent to safely perform the intended testing with, of course, appropriate risk control measures in place. It is very important that handling and processing specimens, including blood for serological testing, lab procedures that are basic for good microbiological practice and procedures are followed. And it is important that the handling and processing of specimens from cases with suspected or confirmed COVID-19 infection that are intended for additional laboratories such as hematology or blood gas analysis should follow local guidelines for processing potentially infectious material. I have received a lot of questions from my colleagues in the lab, especially pertaining to handling samples that are not oropharyngeal samples, and they have investigations for FBC or maybe chemistry. Initially, when you started testing, there was a lot of fear in handling the samples, but we only can advise that every sample that you handle in the laboratory should be handled as though as it is potentially infectious. So with that, you will enforce your PPEs and then run any other tests accordingly. It is very important that appropriate PPE as determined by a detailed risk assessment is worn by all lab persons. Ladies and gentlemen, when I say lab persons, I also refer to healthcare workers who handle any patient with suspected COVID-19. The virus may be susceptible to disinfectants, with proven activity against enveloped viruses, including sodium hypochlorite, bleach, for example, 1,000 parts per 1 million part for general surface disinfection, and 10,000 ppm for in case we have maybe blood spills. You may be aware that the human coronaviruses in general are known to persist on innate surfaces such as metal, glass, or plastic for up to 9 days. As such, all manipulations of infectious or potentially infectious materials must be performed in appropriately maintained, validated BSCs. Lab workers who wear should wear protective equipment, which includes disposable gloves, solid front or wraparound gowns, scrub suits, or coveralls with sleeves that fully cover the forearms. Of course, head coverings is emphasized, especially for those with maybe dreadlocks that are maybe hanging. You have shoe covers or dedicated shoes. Of course, eye protection, which includes goggles or face shield, is also advised. Surgical or respirator masks, e.g. the N95 or FFPs, should be worn. It is important that risk assessment is done to inform the use of respiratory protection. For example, the fit-tested particulate respirator, for example, or the N95, or anything that is higher than that. For patient specimens from suspected or confirmed cases should be transported using the UN 3373, and then they have to be marked biological substance category B when you are transporting for diagnostic or any investigations. Of course, when you send the samples within the national borders, you have to comply with regulations that are applicable with the national regulations. But then when you ship them outside the country, you then have to follow the United Nations model. The next few slides that I'm going to discuss now go into the respiratory sample collection and packaging. Of course, in preparation to perform proper sample collection, you need your ammunition, which includes the collection vials or tubes with a universal viral transport media. It is either universal transport media or viral transport media. You also need personal protective equipment. You need your case investigation form. And I have to emphasize that it is very important that the case investigation form is completed appropriately. And I see I have I've not included also the case reporting form. It is important that this form is also completed because it is one of the forms that helps us to initiate even the surveillance processes. We need a marker, of course, for labeling the samples in the vials and the tubes. You need a pair of scissors. You need a turn depressors. You need secondary container. Of course, you need a cooler box with ice so that you can contain the samples. This slide just reflects on just for people to appreciate the previous slide that I discussed, you can appreciate the gowns, gloves, PPE, and the N95 as well as the goggles. Now, the universal transport media, currently in the country, we use the viral transport media. So this is used to collect or contain the samples for viral isolation and testing. And the mixer there is essential for viral studies or viral survival. Recently, there is recent literature, even though it has not been published, where some authors looked at the different performance of the samples transported in the normal saline, some transported in the viral transport media, some universal, and the good studies have shown that there is no difference in viral maybe detection in the laboratory. So we are expecting that publication to also help us survive through difficult times when we do not have viral transport media. This transport media prevents specimen from drying out. And the good thing is it also prevents bacteria and fungi growth, because remember, at the moment, our target is the virus. So you want to contain the specimen in something that is going to inhibit bacteria and also fungal growth, and only allow us to get the virus, which we are interested in. That is just a picture of one of the tools that you need, which is the SWABs, which we have to note that they should be Dacron or polyester fiber tipped. And please let us remember not to use cotton swabs with wooden shafts. This slide is just a repetition of the introductory slide that I spoke about on the types of specimens to collect. And I have highlighted the ones that we are going to be concentrating on for the purpose of testing or isolating the COVID-19 organism. And this is the oropharyngeal throat swab, and the nasopharyngeal swab. Let us look at the procedure or the steps that we go through so that at the end of the day we get a swab, oropharyngeal swab, that will allow us to detect the virus from an infected person. First of all, you use the sterile oropharyngeal swab that is usually supplied with the kit, and if needed, you use the depressor to hold the patient's tongue out of the way, so that it allows you to visibly see where you want to collect the samples. And then you swab the posterior oropharynx, avoiding the tongue and the tonsils. And the patient should resist gargling and closing the mouth while the swab touches the back of the throat. My timekeeper is warning me about time, but I believe I'm doing well. For the nasopharyngeal swab, you gently clean out visible nasal mucus. And cleaning this is very, very critical, because sometimes you can have some dirt, especially for the elderly who take that sniff, and then it can inhibit your testing. And then you tilt the patient's head back slightly to straighten the passage from the front of the nose to the nasopharynx. And then prior to insertion, measure the distance from the corner of the nose to the front of the ear and insert the shaft only half its length. And insert the swab provided along the medial part of the septum, along the floor of the nose until it reaches the posterior nares. And then gently rotate. You gently rotate the swab so that you are able to get the sample. Usually you want to allow your swab to sit there maybe between 10 to 15 seconds so that it collects, and at the same time you dislodge the epithelial cells. And then you place the same swab in the same container with the oropharyngeal swab. And then break the applicator stick near the cap. And then you tighten the cap. You are ready to then ship them to the laboratory. And when you are ready to, when you have collected your samples, then you store your samples at 4 degrees Celsius. And then, like I mentioned, you will ship them within 48 hours. Now, when you package your samples, you need a cooler box. You ensure that you do your triple packaging. You do your labeling properly, and then ship the samples the same way you ship samples for maybe FBC or chemistry. And it is very important that the forms that contains any information pertaining to the patient accompanies the specimen. And I have in my last slide a brief or something that is always handy when you are in the field, that you can, it is actually procedures on how to collect the sample and then up to shipping to the laboratory, that I encourage everybody to be keeping close by as part of reference. Thank you.
Thank you very much, Mr. Maruping, on such a detailed and important topic. Good illustrations. I apologize for for us not keeping time, but this was very, very important for us to go through. I'll allow the next 10 to 15 minutes actually for questions, and would invite the different presenters to respond to those questions depending on the theme. So please, anybody who sits with a burning question, go ahead.
Hello, can I ask a question, please?
Yes, please, you can do that.
Okay, thank you. Let me first introduce myself, please. My name is Jelena Mitrovic. I am the director of Young Africa Botswana. It is an NGO. We are training young people to become employable. We are helping them with these skills. So, and we were invited to this meeting through European Union. And I have actually 2 questions, and I don't know, you can say who would be the best person to answer. The first one is about, there's obviously, it's referring to the first presentation and of Mr. Jarvis, and it is obvious that the way forward, a safe way forward, is directly connected to testing. And that is something that, let's say, I believe all of us, the people who were invited in the meeting, we just, let's say, it is about the capacity of the government to test. So we have learned now all different, very important information, but it still doesn't say, and that is the only thing that I'm not hearing in the news. Government is very transparent, and I am fascinated. I am feeling very proud. I'm feeling very safe by the way how government is dealing with the whole situation, but we don't know anything about how the capacity of testing, and if this is a period of us waiting for something to happen, does it mean that the government is looking for funds to invest in the testing? That is my first question. How can we get more information about a strategy for testing? And the second one is what I also asked by email, considering that we were invited for this meeting and we are from the NGO, I think that we can play a big role in communicating with the community why it's important to adhere to the measurements. Is there any way that we can get in contact with the government, which we tried through our partners, to offer more of our help?
Thank you for those two important questions. I think I would ask a representative from the Ministry of Health to touch a bit on those.
This is Dr. Bono. The second question concerning support from partners. We are working with PEPFAR, CDC, and all the PEPFAR and CDC partners in how they can assist the Ministry of Health in order to end the response for the COVID-19. So I don't know which partner, developmental partner are you supported by. So please communicate through that partner, if it's PEPFAR or CDC. If it's PEPFAR or CDC or USAID, just communicate through them and then we can see how we can.
We're working with the Ministry of Youth. Is that a right partner, or should I go through different channel?
So let me give you my email address so that you can ask me specific questions concerning support. We are not directly working with the Ministry of Youth in terms of support from partners. So I wouldn't know which partners they are working with. So in terms of the health side of the response, public health side of the response, you can talk to me directly and then we can see how we can work with you.
And about the testing?
Thank you very much.
The other question was, what about the testing, strategy for testing?
Yes, then the capacity. Okay,
so as you know, currently we are testing suspects. So you have to be fitting the case definition and therefore be a suspect for you to be tested. The other ones who are tested in quarantine, yeah, that's a topic for another day. But we are testing suspects, and currently the lab is able to test as suspects. But we do admit that we don't have enough test kits and even maybe transport media for the next maybe month or two. So the ministry is currently procuring more locally, and there's also a plan to get a big consignment from China.
Hello.
Thank you very much, Dr. Obon. Another question from Dr. Jibril.
Well, it's not a question, actually, it's a suggestion in terms of partner forum. It would be nice for the ministry to expand the partner forum to include other partners like the last speaker, so that we can have a wider spectrum of suggestions and maybe plans on how to proceed forward. So I just propose that they expand the partner forum, and then probably the ministry can then be reporting the proceedings, at least a brief summary of what they do on this forum. Thank you.
Okay, so the Emergency Operation Center for the Ministry of Health is at the ministry of conference room 1F2. So if you are a partner and you want to support, we are available there every day, even at night.
Thank you, Pono.
Thank you very much. There were also other questions that have been forwarded before the presentation that Mr. Maruping, who had the last presentation, wanted to answer.
Thank you very much. There are plenty of questions, but like I said, most of the questions that are here are questions that are focused on the actual testing. And I believe we will have another presentation where we'll tackle a lot of those. But one of the most important questions that has to be responded to is the one on turnaround time for results. The turnaround time is 72 hours, but I am happy to report that for the past, I think 3 days, we have been doing well, and our turnaround time was actually 2 days. And how long does it take for the results to be available? I think this is almost one and the same question, right? And a lot of questions are into like strategy, which has been answered by my colleague. And the Director of Health Service once mentioned rolling out testing to labs outside the Gaborone. Of course, those are the plans that are in place. And as to how far, this is affected by a lot of issues. You are aware that we have had a lot of countries doing lockdown, and we depend on other countries to bring new test kits and everything for us to do that. But it is something that is going to be coming shortly, I think in less than 3 months or so. Basically, that is that. Thank you.
Thank you very much. We're still open for receiving more questions.
Hello.
Hello.
Hello. Hi. This is Dr. Muyela. I was hoping to ask a question.
Please go ahead.
I wanted to hear from Ministry of Health, what are our protocols on testing healthcare workers? I feel that this is very important for us to know. And can we please have this protocol so that we know, because we have healthcare workers working at points of entry, quarantine sites, and A&E, also at SPECIMEN. So I just wanted to know what are our healthcare worker testing guidelines, please.
Please, somebody from Ministry of Health.
I thought we were taking some, but anyway. So currently we don't, like I said, we test according to the case definition. We don't do routine testing of healthcare workers.
Hello, may I ask a question?
Yes, you can ask a question, Max.
Okay, thank you very much. Yeah, my question is back on the testing capacity. Like Mr. Maruping said, you can the turnaround time. That was one of the things is 72 hours. But I think, is it possible for him to tell us, like for the time being, how many tests are we able to conduct, like in a day?
Thank you very much for the question. I am happy to report that we can do between 800 and 1,000 per day because we have optimized and our laboratory. One thing that we have to realize is the long turnaround time that has been there was because we were testing in the NHL and then sending our samples to NICD in South Africa. And during that process, we were not releasing results until the results came from South Africa. So this contributed to a longer turnaround time. Now, the fact that we recently got approval from WHO to test independently, this has drastically now reduced the turnaround time, because we test the samples and then take out the results without intervention of the external laboratory. And then we have also now automated our extraction process. Instead of doing it manually, now we are doing it automatically using the nucleosynthesis equipment. And this has increased our capacity to do extraction and then detection. As such, we can do between 800 and 1,000 because we now work also 24/7.
That's very good news.
Thank you.
Thank you. Yeah.
Thank you. I think we'll open for one last question.
Hello. Can I ask?
Hello.
Yes, this is Joe McHam. I'm calling from the BHP. Thank you very much for all the presentations. I don't know whether Professor Jarvis is still on, but I just wanted to ask about and once again throw caution about our community testing. As you know, we all have been emphasizing and all around the world that testing. And currently in terms of the strategy that is being rolled out for community testing, my anxieties are about the methodology of it all, because at the end of the day, you want to be testing as much as possible those people who are symptomatic and contact trace those and quarantine those, whether they may be in the communities, whether they may be in hospitals, or wherever you may find them. But I think this strategy of testing asymptomatic people may be just a waste of resources, and we may not be focusing on where we may get maximum returns for the resources that we have at our disposal at this point in time of this epidemic. So I just like Joe Jarvis perhaps to talk to some of that and the methodology. And as I say, for me, I really have reservations and have expressed those, and I still think for the resources we have at this point in time, we are not focusing those where we really should be. Thank you.
And before Professor Jarvis responds, this is Doreen Masire. I think I would actually want to emphatically support Ramakema on what he's just said.
Well, thanks very much, Joe and Doreen. I mean, I think you both know my opinions on things. The absolute key thing that we need to be doing now, so to be clear, lockdown doesn't get rid of coronavirus. All lockdown will do is suppress the epidemic until we lift the lockdown restrictions. And we can't stay on lockdown forever. So the only way out of lockdown, if we don't want to have a coronavirus epidemic, is to do very widespread testing of symptomatic individuals. We need to rapidly identify cases, and then we need to rapidly do contact tracing and quarantine of their contacts to prevent community transmission. So to do that, what we need to be doing is having very widespread and easy access to coronavirus testing for all people with any possible symptoms of coronavirus. And my feeling would be that that should be being done in every clinic and healthcare facility in the country, plus some mobile testing to go out into the community to try and identify symptomatic individuals like they're doing in South Africa. Because that is what we need to do to control the epidemic. Going out and testing very large numbers of asymptomatic individuals is likely to be quite a low yield exercise. We would expect that at this stage in the epidemic in Botswana, a very small overall percentage of the population would have been infected. So you'd have to do a very large survey of asymptomatic individuals to find those who may be infected or have asymptomatic infection. And although there is asymptomatic infection and asymptomatic spread, most of these patients do develop mild symptoms or symptoms, and most of the spread is from patients with symptoms. So, you know, I think it's clear from the evidence that we should maximize our testing of symptomatic individuals to try and identify all of the possible cases at this stage in the epidemic. But the overall strategy that's being adopted, I'm not, you know, I'm actually not fully aware of where things stand at the moment, and maybe somebody from the ministry could just outline what their overall strategy is in terms of doing this large community testing involving asymptomatic individuals versus testing for symptomatic individuals.
Joe, just a follow-up question to what you have said about the use of our resources in terms of identifying the case and do contact tracing. I think I will start to follow up on the question that Dr. Charles Muela has asked about screening of the healthcare workers, because what has been shown clinically from this disease is that it has a very mild course in young people and the pediatric age group. And there's a high probability that the healthcare workers, because we are dealing with patients who may be asymptomatic or who may not have been tested, some of the healthcare workers may have been infected and not have been symptomatic. Do you think it's a good idea to screen all the healthcare workers, as the question was asked before?
That's a difficult question. I mean, in most settings, we're not routinely screening healthcare workers unless, you know, if they've been a contact of a known case and we're not wearing proper PPE, then like anybody else, they would be screened through contact tracing. And if they develop symptoms, then of course they should be screened like anybody else. But to just routinely screen asymptomatic healthcare workers would be, you know, it would be very labor intensive and difficult, because you'd effectively have to screen all of the healthcare workers every day for it to be of any use, really. So I think the current recommendations are that if healthcare workers are contact like anybody else, they will be screened. And if they develop symptoms, then they would be screened. And I think that that's reasonable advice. That's what's being done in most other settings.
Yes, this is Joe Mukhema. I didn't know which was being asked to, but certainly the data that one sees is for healthcare workers in different settings who are symptomatic to be the ones who get tested. If at all you're going to test those who may be asymptomatic, you know, at the end of the day, you know, you don't know when they get exposed, unless if at all they are going to all be using PPEs routinely as standard surgical masks in their different institutions. And then the second aspect about this is in terms of healthcare workers. Remember that at the beginning of the epidemic, all the healthcare workers who tested positive but were not symptomatic were in effect quarantined, and they quickly got to lose staff and they had to change those guidelines. And so it's actually the symptomatic ones who are now being excluded from participating in care. And so I think we should follow the data of some of those institutions. And yes, there are anxieties, and yes, there may be panic. But at the end of the day, I think we should have proper counseling and how we target our resources as we address this particular issue regarding healthcare workers testing.
So I would like to ask a question.
Yes, please, Professor Nakstad, please go ahead.
Yeah, thank you. I hope I didn't misunderstand, but as I understand, it's 15 positive cases in Botswana among 3,400 being tested. So at least in my home country, we're talking about the R factor. How many people can one infected person transmit the disease to? So in Norway, they are opening up for schools and everything now. What is a recommendation from the health authorities in Botswana? Which R factor are you aiming for to lock up everything that's affecting us nowadays? It means like a small number of infected persons in Botswana, and it's been a week now since lockdown, and it's 2 more. So it's not a high number.
Hello? Can I ask a question?
I think I would project that question to Prof. Jarvis if he can comment on that.
Well, I mean, I can't make any comments on behalf of the Ministry of Health and Strategic Policy, I'm afraid. I can kind of address the question of what we're doing in terms of the R factor or the transmissibility of the virus, because what other places have done is they've effectively had epidemics starting. They've put in place their social distancing measures, and the aim has been to get the transmissibility, the R0 or the RT, to go below 1, which means that each person needs to infect less than one other person, and in that case eventually the epidemic would die out. And what they need to do with their measures is to maintain the RT or the R0 below 1 to make sure an epidemic doesn't take off. So they've got their RT down below 1. They're now trying to relax the social distancing measures while increasing testing, contact tracing and quarantine in a way that will keep R0 or RT below 1 and stop an epidemic taking off. Now in Botswana, we've never had an epidemic, so we've kind of preempted this. We put in place a lockdown before we even had many cases. So as you say, it's a difficult question to know when does Botswana lift its lockdown. And to do that effectively, you really need to know how many cases we have. And the fact is that you saw the testing numbers. It looks quite impressive, but of those 3,000 tests, over 2,000 were in generally asymptomatic individuals who've been put in quarantine since returning from South Africa or flying into the country from elsewhere. They're not symptomatic patients with possible disease. So the number of patients we've actually tested who've had suspected symptoms, suspected cases, is a bit less than that number. So until we know for certain really what's going on, it gets very difficult to know when you can lift the lockdown and how. So I think it's going to be another couple of weeks and increased testing to find out what's happening before we can really address that question of what we do next.
Thank you very much. I would like that to be the last comment. It's time now to wrap up our session.
Hello.
Hello.
Hello. This is Dr. Mompati from Francistown. I would like to thank you for giving us this lecture, Prof. Jarvis. My concern is we are now at the moment in lockdown. We have done very well to be proactive by doing the lockdown, but I would concur that we should really do testing to find out the contacts. Right now, there is this policeman who came from UK in February. We only got the results today. How many people has that policeman infected? At the family level, at work level. He has been asymptomatic before. So unless we do contact tracing, we'll never do away with lockdown. So we need to find out which regions are being hotspots for this virus so that we can contain it. Thank you.
Can I ask
Thank you very much for that.
Can I ask a last question?
Last question.
Yes. Can I go ahead?
Go ahead.
Yes, thank you very much for all the presentation. Well done. I think most of the questions have been answered. But the last one I would like to know is, since we got the first case up today, we have 15. But among the indicators or the variable, I don't see how many patients have recovered from the virus, because this actually may help us to measure our case management. So could you tell us how many have recovered from the 50? Thank you.
Dr. George, I know you're on the line. Dr.
Yeah,
George,
sorry,
I know
didn't-
you're on the line. I'm throwing it at you since you are frontline at the Sekitumila Admission Center.
Hello.
So basically what I'll do, I'll answer.
Hello.
I was just.
Hello. Dr. Olat.
Yes.
Yes, I was going to say we will have that, just to answer the gentleman's question, we will have that answer probably in the next couple of days. We are actually discussing that this morning in terms of the first batch of patients that we've admitted. So we'll be able to say whether or not we've had recoveries.
I think basically at this point, though, we don't have what we've documented as a recovery until we give that feedback.
Well, at least in the European countries, the asymptomatic patients are transfecting very few. In Norway, the number is very, very low.
Thank you. Thank you for that comment. As we can see, there are, of course, a lot of questions. A lot of them has been answered through the chat box. We thank our moderators for that. And there will, of course, be a need to continue this discussion. And we are planning a webinar already this coming Tuesday to look closer at the clinical management of COVID-19. So we will continue in the upcoming seminars to address other issues related to this and other subspecialties. So let me take this opportunity to thank all of you for attending. We had at some point more than 200 who had signed in. And of course, we have made the interaction interactive as wished. So let me take this opportunity to thank you all for attending, and we look forward to seeing you again next week.
Thank you.
Okay, thank you. Thank you very much.
Thank you.
Thank you.
Thank you very much. Very much.
Thank you.
Thank you.
It was nice.
And you go